Good night, everybody. Well, it's 8 o'clock. Well, 8:01. Let's wait until 8:05, okay?
Okay, teacher.
I think it might be nice to wait a little bit. We are just 7. I'll be back in 4 minutes, okay?
Okay, teacher.
Okay, it's 8 and 6. Let's start, okay? I'm gonna share a screen and then we start the class for finishing on time. Can you watch my screen?
Yes, teacher.
Okay, let's go. Today we have a very theoretical class. I mean, with lots of vocabulary and information. That I think is very important because, well, we have to talk about screening and immunization, a general view. In this general view, I'm not taking into account the vaccine chart or the most common vaccines because, well, at this point, it's out of the objective, okay? We are going to see big details of this kind of topic. Of course, we are going to check lots of meanings in epidemiology and the general view about the medical ethics. In that way, well, let's go. Screening and immunization, of course, very, very important topic. We all know how important it is to get vaccinated on time, following our rules, we can say, or the worldwide rules in order to get protected, right? That's why we got these meanings. Screening is a way to identify, a way of identifying people at increased greater risk for a condition, although they don't yet have any signs or symptoms, just for catching the risk, of course. In some cases, mass screening large numbers of people, is appropriate, for example, in the past for tuberculosis. In other cases, only those with high risk factors like family history of conditions such as cancer, diabetes, or any kind of situation are screened, just the ones who have that risk, of course. However, there are a number of problems with screening. There are always false negatives, cases where a patient has a disease, but the screening does not identify it. And there are also false positives, where someone is told they have a disease when in fact they do not. Furthermore, with some diseases, early identification is of no benefit to the patient as there is no treatment available. We can catch this idea while talking about this epidemic period, the pandemic, the pandemic times, thinking on the first cases that were diagnosed, there were no treatment that was recognized as a solution. We all were scared because with the COVID-19, we didn't even know how the chance to consider the correct way to make the diagnosis, to follow the epidemic times about this infection. Nowadays, of course, it's very different because we all know how this process is going on. But thinking of the beginning, we also had, of course, lots of false negatives, lots of false positives, and it makes us to lose a little bit of control. We can remind it that maybe it's the same in every country. In general words, thinking not just on infective or infectious diseases and illness, we must consider the common screening tests, the common ones, in order to follow, to find the situations or conditions that maybe are not daily process to find, maybe, or maybe that we are fighting again in order to improve our health indicators. For example, thinking about this first condition, the neural tube defects and Down syndrome risk, specifically on this, in your own experience, how many patients you by your own getting diagnosis of this in your hospital while you practice? If we follow the common screening test, the AFP alpha-fetoprotein, that is practiced on pregnant women between 16 and 17 weeks, yeah, very easy. When we catch this information, it's not a common situation to find it because nowadays we know the treatment, how to prevent this condition. We know how to prevent by taking pills, stop smoking, following the prenatal control, right? The same with breast cancer. One of the most common studies or the most common screening test to find it is mammography in women from 50 to 70 years old. And according to the situation, it may be developed every year or every 3 years. The same as with cervical cancer, when we talk about the smear test with women between 20 to 60 years old, or women who has intercourse, right? According to the situation, we can take it every 3 years, every year, every 5 years. Well, we all know when we exchange the period or the frequency for taking the smear test. About cardiovascular disease, one way to make the assessment of the common screen test is the blood cholesterol with over 40 with high risk factors, just the ones who get all the conditions to be into this group. And well, the frequency must be here. When we talk about secondary prevention, we take in account that patients that has the condition, and we must take control in order to follow the situation, looking for complications, okay? For example, when we get a patient with cholesterol over 40, we must make the blood cholesterol control. In patients with heart disease, that's the requirement, the strongest one. This control must be every 6 months without any change. Why? Because following this cholesterol, we can say that the blood cholesterol is the best test for reaching the objective about prevention or not. If we have a patient with diabetes, and this patient has a diabetic retinopathy as a consequence of this disease, we must send him to the ophthalmologist to develop the ophthalmoscopy. Of course, the subjects are patients with diabetes, and it could be every year or every 6 months according to the situation, right? Take it in account, very important in my opinion. And as I was telling you at the beginning of this slide, we don't have to be enclosure in the idea that immunization is just for people, well, screening and immunization is just for people with infections, or we are only following the the vaccine program that every country has. We can make the screening for everything, for every disease, every condition, in order to organize our population. Other common or some common screening tests, this list, of course. Well, the pap smear for cervical dysplasia or cervical cancer, we were talking about it. Fasting blood cholesterol for heart disease, we were talking about it. Fasting blood sugar for diabetes. Blood pressure for hypertension, very easy to take. Everyone has the chance to do it. The mammography, we're talking about it. PSA test, of course, very important. Prostate-specific antigen for prostate cancer. Fecal occult blood for colon cancer. Ocular pressure for glaucoma. Nobody takes it into account, but it's very important to make this control. PKU, test for phenylketonuria in newborns. TSH for hypo or hyperthyroidism. So taking it into account, they are very common. In some other countries, they are under control by the government, and everyone has to make this screening test in order to check how healthy they are, and then let the government provide or to give the chance to continue taking care of patients, right? In our country, we have some of them. For example, the HEAL test in newborns, that is testing 5 different diseases. In the order, just as a general information, right? Talking about immunization, thinking on travelers, of course, that people who's spreading infections everywhere. We should consider and take in account that the travel vaccines are specific immunizations given to travelers prior to going to certain areas to protect them from acquiring serious life-threatening diseases. Right? If you're going to Asia, you need a specific kind of vaccines. If you're going to USA, you need another battery of vaccines. To Europe, the same. To India, the same. But we must consider this. What does fully vaccinated traveler mean? You don't have the obligation as a traveler to get all the vaccines that are required at the moment. According to the period of the year you are traveling to a country, you have the chance to consider this. If you have received both doses of an accepted 2-dose vaccine series, regardless of how long it has been between doses, you are considered full vaccinated. It's according to the period of year. I'm repeating this because it's not for every period in year. So let's take it in account. Here, vaccines for travelers again, we have this chart. I'm sorry. When we get a general view about the most important vaccines you need for going to different areas into the world, to Oceania, Asia, Middle East, Europe, Africa, Central and South America, North America. So you can see this chart is previous to COVID-19. Now you need the COVID-19 everywhere according to the place you are going, is the factory the vaccine has to be developed, right? It's not the same. For example, if you're going to North America with an anti-influenza virus vaccine, and you only have this, you cannot go just with this to Africa. You need the anti-yellow fever vaccine, of course, the malaria vaccine, of course. While I was living in Cuba, there was an obligation to get the malaria vaccine and anti-yellow fever vaccine. If you didn't have both of them, you cannot get into Cuba. And while getting into there, you must stay in observation, epidemiological period for 7 to 15 days. Okay, so according to the situation, the place you are going from, and the place you are arriving, the country you are going, So maybe you must stay in quarantine, in observation, right? So take it in account. Here we have this list with lots and lots of details. So let's consider, okay? Well, here we have lots of terms, blocking words and expressions, talking about a specific group of vaccines. So the following vaccinations are recommended for travelers to South Asia. You can see to a specific area. Hepatitis or immunoglobulin IG, right? We have this expression, person-to-person contact. Transmission of hepatitis A virus can occur through direct person-to-person contact, through exposure to contaminated water, ice, or shellfish harvested in contaminated water, or from uncooked fruits, vegetables, or other foods. So you can see, very important, person-to-person contact and exposure to these expressions are the ones that we are going to use. Hepatitis B, especially if you might be exposed to blood or body fluids. For example, healthcare workers, we all as a healthcare providers have the chance to get in contact with the fluids and then get infected, right? Or have sexual contact, intercourse with the local population, or be exposed through medical treatment. It happens. It shouldn't, but it happens. The Japanese encephalitis. If you plan to visit rural farming areas and under special circumstances, such as known outbreak of Japanese encephalitis, so consider this. It's a very, well, not an extremely common situation, but it occurs in a place of this. In a place like this, I mean, the outbreak, when it's the period of the year when this situation starts and the infection gets, we can say gets free, okay? Malaria. Your risk of malaria may be high in these countries, including cities. Travelers should take an effective anti-malarial drug. The prophylactic treatment, preventative treatment. Rabies, of course. If you might have extensive unprotected outdoor exposure in rural areas. Rabies here in Latin America, well, the most important are from dogs and cats, well, animals, from pets that are at home. But of course, monkeys can spread this and can let us to be, can let us in exposure to this infection. Monkeys, rats, that's why we have to consider this. The typhoid fever can be contracted through contaminated drinking water or food. Large outbreaks are most often related to fecal contamination of water supplies or food sold by street vendors. Okay, so let's take account. Sometimes vaccination is particularly important because of the presence of Salmonella typhi strains resistant to multiple antibiotics in this region. The resistance to antibiotics is very, very, very important. And this problem, as a fact, nowadays, well, it's considered a cause of death. That's why we must take into account vaccination. Well, as needed, according that you need or not, booster doses of tetanus, diphtheria, and measles, and one-time dose of polio for adults. Please check this vocabulary, practice on this, okay? Talking about epidemiology, well, we must consider that this is one of the biggest branches into the medical career in a general view. Why? Because you have all of these activities to follow when you become an epidemiologist. It's not as easy as it looks. It's not just having fun with numbers. Of course not. One of the most important activities, in my opinion, is the infection control, following all the steps that it really needs. Epidemiology is as a general view, is the study of the distribution and determinants of health-related states or events in specified populations, and the application of this study to the control of health problems, right? To take the control on a health situation is not just sending guidelines, it's following all the process and teaching our colleagues, teaching population how to prevent, how to treat, and how to manage the situation. That's why we have this chart, we can say. Well, we can see, we have the health department, we have the public and healthcare providers, and they work together. Like or not, they work together. Public healthcare providers, clinicians, laboratories, hospitals, well, all the medical staff, the medical workers are reporting, are giving information to the health department. Health department analyze this information, organize the things that we really need, and then we send a feedback again to the public and healthcare providers. They read, they study the feedback, change the lines, the rules, we can say, and then we report again with the new conclusions to the health department, and it's a cycle that never ends. If you think on the COVID-19 period, we can say this cycle was very clear because every day we were receiving information about treatment, new ways to take care, the process of the vaccine, how it has been developed. And well, if we think a little bit on this chart, that's true. We work like this. For working on this, on the feedback, for giving a good conclusion, we need to study rates. We need to study numbers. We have to be objective. We must be practical and take into account numbers. Without, well, an investigation and screening, how to check the immunization, how to check in epidemiology. If we don't have indicators, we don't have rates, there is no possibility to support the research, to support this activity. That's why we have to get used on these expressions. Rates, the speed or frequency with which an event or circumstance occurs per unit of time, population, or other standard of comparison. Okay, let's consider this. When we talk about the rate, we have lots of rates. We are going to check the birth rate, death or mortality rate, case fatality rate, and survival rate. And as you can see, all of them are the number of births in a population, a group of people, is the birth rate, and the same with the rest. The death rate is the number of deaths in a population. No matter the causes, we are just checking the big number. The case fatality, the number of deaths from a particular case. We are studying why this people is dying because of this specific cause. And the survival rate, the number of patients still alive after treatment for a particular disease. Why? What I am doing is so good for getting my patients alive, instead of this new treatment. Very important rate. And the way to express this information is like this. It's an example. The birth rate in Singapore could be is 10.2 per 1,000 population. We have another one. The infant mortality rate in Singapore is 3 per 1,000 live births. So you can see, that's the way we can give this information. Other words that we can use for talking about frequency, common, uncommon, or rare. Uncommon or rare as synonyms, okay? For example, malaria is common in many developing countries. On the other hand, malaria is uncommon in developed countries. Malaria is rare in developed countries. Here you are giving us the idea how developed is that society, that population, for being common or uncommon about this kind of situation of infection, right? We have lots of examples here just for checking as a first view. The graphics, the causes from rate during the year. We have specific causes that are being studied through the time, through the years. I think it's interesting. And now we have a new meaning, incidence and prevalence. Prevalence, the number of people in a population who have a disease at a particular time, in a specific period of time. Incidence, the number of new cases of the disease during a particular time. In that specific time, how many new cases we get, okay? Prevalence, all cases. Incidence, new cases. This mnemotechnic is useful. Take it in count, right? About expressions, talking about it, we can say the incidence of malaria is high in many developing countries. The incidence of malaria is low in developed countries. So you can see these words are expressions that at this point are useful or valid. You can use them instead of giving numbers. We're making it more interest, maybe. When we make comparisons, we use, of course, the common English, following the same rules. For example, the incidence of HIV infection is highest in sub-Saharan Africa. The incidence of HIV infection is lowest in the Caribbean. You can see the same. Rheumatoid arthritis is more common in females than in males. We're making a comparison. Rheumatoid arthritis is less common in males than in females, right? Men and women are equally affected by restless leg syndrome. This expression, equally affected by, these three words are showing us something that it's not in difference in numbers, okay? No, they don't say the incidence of malaria is common. It's out of sense to say that it's common. We say that it's high or low according to the place you are talking about. The incidence of a disease is in different groups are often compared, as you can see in this case and this case. Making this comparison is better than giving numbers, right? Another concept, association and causation. Studying the incidence of disease in particular groups of people can lead to the discovery of causation, what it makes it occur. For example, the high incidence of lung cancer among cigarette smokers suggests that the smoking is a causative factor in the development of lung cancer. Nowadays, we all know that it's true. We all know that the smoking is a causative factor of lung cancer. Just for being clear, and this example to take in count. However, care must be taken not to assume every association between a disease and a measured variable causative. To say there is an association between two things simply means that they occur together in a certain situation, in a specific situation, okay? For example, we have this another way of thinking about lung cancer. Several studies have indicated high rates of lung cancer in cooks, right? Although this could be a consequence of their work, perhaps caused by cancerogens in film from frying. It may be simple because professional cooks smoke more than the average. In other words, smoking might confound the association with cooking. What it means, not everybody with lung cancer has lung cancer because of smoking. There are many other reasons that we must take in account. For example, cooking with woods in lands. It's a causative factor of lung cancer. In this chart, we see the risk factor, low CES, the social determinant. Low CES means that people with low resources, people from the third world, we can say. Component causes, well, the risk factor is the low CES. We have the component causes, tobacco, smoke, and pollution. The biological effect, of course, is not going to change independent to the component causes and the risk factor. Mutation in respiratory cells. The health outcome, the lung cancer. This chain is just showing us the process of becoming with lung cancers from the risk factor, the component causes. These component causes are associated to the risk factor, and both of them produce the biological effect. Okay. Talking about medical ethics, well, there's a very important topic, I think. We must consider that since medicine is medicine, well, we must be sure that always we have the obligation to think and to work in order to give our best and to show and to look for the most important benefit to our patient. Medical ethics is concerned with the obligations of the doctors and the hospital to the patient, along with other health professionals and society. Health professions has a set of ethics applicable to different groups of health professionals and healthcare institutions, right? We have rules. We must follow those rules, looking for the benefit of our patient. But this benefit can be affected because the way we think, the laws of the moment, the insurance, health insurance, of course, it's not easy to fit all of this information. Tell you by experience. That's why we consider 4 pillars of medical ethics. These 4 pillars are developed at the beginning of the medical career because we as doctors give advices to our patients while getting in contact with him. We can show a treatment, but if the patient is not in accordance, we can say, to our idea, the patient doesn't agree with us about the solution, well, we decided to be doctors and we have to look for another alternative, another way of thinking, and looking for another solution maybe. Yes, as Jorge says, primum non nocere. That's One of the most important ideas, of course, in Latin, yes. We have the pillar of beneficence, the pillar of non-maleficence, the pillar of autonomy, I really hate it, and the pillar of justice. Okay. About the pillar of beneficence, let's talk about it. It's about promoting the good of others. We as doctors, as I was telling you, look for the beneficence of population. If so, if we would like to make something different, not looking for the beneficence, why we should advise treatment, advise prevention activities? There's no sense, right? In medicine means acting in a way that helps your patient, always. The most obvious example of this is providing up-to-date evidence-based treatments to your patients with the aim of reducing their symptoms or treating their illness. In previous presentations, I told you that one obligation we get while finishing the medical school is to get up to date. It's our job to keep on working, keep on studying all the time, keep on assisting to congresses, keep on attending, I don't know, PG courses. This kind of course is refreshing lots of ideas, of course. And from this point, you might have maybe more keys, more ways to getting access in English congresses. Do it. It's amazing. It's different. The evidence-based treatments are developed in order to follow the research, the screening, to research the new diseases or change the old treatments for becoming in the best ways. In this blue chart, I'm showing you in every pillar specific cases talking about how a specific experience through the medical history is showing us how beneficence was vulnerable, was broken. The syphilis trial, as a general view, I can tell you, please read this for catching vocabulary and reading, is supporting this history. We had in the 40s, well, the development of antibiotics, the penicillin, one of the most important, of course. But previous to that, lots of infections were having fun in population, and of course, lots of people were dying. One of these infections was syphilis. Of course, sexual infectious disease at that moment, now it's a sexual infectious illness. And when the treatment was in research, there was a doctor who said that it would be interesting to apply penicillin in a group of people, of population, and apply a placebo in another group and make a comparison, and then identify if penicillin was effective or not. This doctor, in remarks, went to that population, of course, pure people, and he divided into groups the population according to the age, the activity, how they get in contact in intercourse to get infected. And without asking population, he started applying penicillin to ones, placebo to the others, and comparing and identifying the process of these chronic infections. And then from this non-beneficence procedure, of course, he saved the ones who received penicillin. He established that it was an effective, good and an effective treatment. That was a great way to solve this situation. And on the other hand, he could establish that there was how the process of becoming with primary, secondary, and third phases of syphilis was occurring. The period of time of every phase, every stage. When population discovered what was going wrong, of course, they tried to kill this doctor. They tried to avoid all treatments because they didn't have any knowledge about it. And they were just like rats, like bunnies, lab bunnies. And that's not correct. The beneficence was not being applied. And well, there's too much consequences from this. But making this kind of research showed us, give us the opportunity to study this infection and give a conclusion how it works, how it gets wrong, all the stages it has. But considering the price, how many people dead, it's not the best way to do it, right? Not without knowledge what is going on. They were thinking they were receiving the treatment, but actually that was not the situation. We have the pillar of non-maleficence. Well, it refers not to causing harm to your patients, the primo non nocere, as Jorge was telling. This principle spans a range of applications, such as doctors maintaining medical competence and not giving patient treatments where the risk outweigh the benefits. That's why we have to consider both sides of the coin, we can say. We can check all the consequences, positive and negative, and according to them, we decide if the non-maleficence is being applied or not. If benefits are the most, of course, let's go and do it. If they are not, no, it's not possible. Try not to cause more danger, more pain. It seems obvious that doctors would not want to harm their patients. But it could happen. In that way, we have lots of situations where this pillar was not being on respect, right? So let's consider this. It's shocking when you read and understand that breaking these pillars, the research in medicine was being developed. Read these blue charts just for checking. Consider this as a part of our history, right? About the pillar of justice. The principle of justice refers to fairness within medicine and equal distribution of resources. It's supposed, it's just, I think, an utopic idea to think that everybody has the chance to receive the same treatment, the same evaluation, I don't know. But we as doctors in the medical branches must try to give the same to everybody in order to give equality and equity and justice for everybody, for our patients, for all the population we are treating on. We have to ask for everything. That's why we have protocols to follow. These protocols support that we are working on justice. And we have to ask. So, for example, you need this sample of blood for looking for a specific condition. You need, I don't know, a specific study. At this point, I'm not sure which one to ask for. A viral culture in blood or in lumbar puncture, on cerebrospinal fluid. Okay, you need the viral culture. I don't care how much it costs. Because of justice, I'm asking for this study because it's the one we need to get the diagnosis. It could be unfair for my patient if I not ask for this. The patient has the decision if it takes or not the option. But for justice, we have to ask for this. It's our obligation. When we talk about equality, equity, and justice, it's very easy, well, checking this picture. Equality, giving everybody the same benefits, the same supports, the equal treatment. But it doesn't mean that it's correct for him, for example, because it's not helping him. Going to equity looks better, but consider this. I'm giving more resources to the one who has less conditions, okay? And I'm not giving everything. I'm not giving anything to the one who's maybe in the best position. That's equity, to give everyone that they need, okay? Just considering the condition they have. And justice, given the same for everybody, looking for same conditions for everybody. Check this, consider this, it's very interesting. The pillar of autonomy, as I was telling you, the self-determination, refers to a patient's right to make their own healthcare decisions. It's also known as self-determination, of course. It means that the patient can decide their own healthcare priorities. And it includes the right to refuse treatment. And as doctors, we should inform and advise patients according to medical evidence. However, the final decision should always lie with the patient, even if it goes against medical advice. We can give the advice as doctors. We try to look the beneficence, we are on justice, but if the patient says no, it's no. If the patient is sure about this decision, there's nothing to do. We have to support, to stand, to take a deep breath and go ahead. There's no other way of working. The most common example on this is the Jehovah's Witness about refusing blood transfusion on religious grounds. Why they refuse the blood transfusion? Because Jehovah's Witness consider that soul is into blood. Their spirit is in blood. So it's not correct for them to receive the soul, the spirit from someone else. This may seem medically unwise, but the patient has a right to refuse this treatment. They can decide if they want to do. They can tell us as doctors when to stop, when to finish a treatment, when to finish a maneuver, a technique, or something we are developing, and they take the decision, thinking that it's the best. Of course, we have the obligation to persuade, to inform, to give a clear explanation, to give the most important information about it. But if they say no, we get into medical and ethical challenges. And well, there we can get supported by laws, by the benefit of patients, but if the patient with all of the ideas, clear ideas, says no is no, right? Sometimes it's frustrating, but well, there's no other way of working. While talking to the General Medical Council guidelines, it's referring about a paper. That paper is giving us the guidelines how we must work or not. This is just a fragment, a small fragment of this. When we can see how we must act, we can say. The duties of a doctor registered with the General Medical Council include: make the care of your patient your first concern. Patient is our priority. We all know about it. When we finish the medical school, we know that our social life is dead. We are always on shift, post-shift, pre-shift, who knows? But if a patient needs us, we must go. It's our obligation. Treat every patient politely and considerately according to the situation. Because, well, as doctors, I think, and according to my experience, we are like an authority. In the way we treat the patient, they are going to treat us, of course, but we are showing the patient how to recover, and it's really appreciated. It feels great. Number 3, give patients information in a way they can understand. It's not the same to talk with a farmer, of course, to talk to a colleague, to talk to an engineer, to talk to a teacher, to a professor, right? According to the situation, we must fit our language, we must fix it and talk in a way that they can understand. It's not correct, it's not ethical to talk in medical terms with someone who doesn't have the chance to learn how to read or write. Okay, so let's consider this. Number 4, keep your professional knowledge and skills up to date. Obviously, number 5, recognize the limits of your professional competence. Very important for not being or not making huge mistakes. Our mistakes are covered by soul. If we make a mistake, that was the most common expression in Cuba. If you are late in the med school, you are going to be late every part of the world during the career, they used to tell us. And all of the mistakes you have for being late are going to be covered by a dead patient. While being in practice, I must recognize that they had the reason. It means not to develop activities when you are not qualified. If you are not on practice about making CPR, for example, the correct procedure, the correct maneuver, following the correct steps, don't do it. It's not a sin not to know how to do something. We are not robots. We are humans. We have the chance for not doing this, for not having the knowledge on a specific topic. That's why we get on a specific branch, we get on a specific way of practice, and then we decide where to continue. As I was telling you at the beginning, it's not possible to make everything all the time. Number 6, be honest and trustworthy. Very important. Always say the truth. Always, never lie for sounding better, for sounding nice, or trying to give a patient a new light. No, always say the truth. No matter how hard it is, there's a way to give bad news. We're going to study the most common protocol of this, just as a review, but it's important, okay? Number 7, respect and protect confidential information. Every patient is a world. We have to be confidential in this idea. Don't share that information. It could be a huge trouble if we do it. And be on the patient's shoes. That's why we wouldn't like to give it as a free idea, right? Make sure that your personal beliefs do not prejudice your patient's care. So clear. We are doctors. We have to be open-minded and consider all the possibilities before treating people. If we are not sure if it's our way of living or thinking, in medicine, we have branches where we don't have touch in people. Pathologists have that opportunity, just work with body pieces, right? Number 9, act quickly to protect patients from risk. If you have good reasons to believe that you or your colleague may not be fit to practice, right? The same, if you are not sure about a procedure, refer to another one, ask for help. Don't be shy about it. It's not good. I had a colleague when I was in my province time, my province practice, who was not sure how to make sutures. Everybody could say that it's easy, how it's a basic activity. But if you don't fit with that activity, well, it's not for you. You have to recognize that. And he always was asking me for making the sutures of his patients. And it's just so nice because I love to do it. But it's different. If you're not comfortable developing a procedure, don't do it. There's more people. There's no doctor. If you're alone and have no other way to do it, well, patience. If you're not sure how to a critical situation, for example, if you're not sure how to place the orotracheal tube to intubate a patient, don't do that. As Jorge said, primum non nocere. Primum non nocere, always. It's better to say, I don't know how to do it, than making a mistake and getting a complication of our patient, right? Take it in account. About the bioethical issues, of course, we have definitions to consider. For example, euthanasia, human fertility, how these ideas get us in controversy, we can say. About euthanasia, should the medical profession help the terminally ill to end their lives when they choose? Life is going to end in the time that it's proposed, we can say. But it's correct for us to accelerate this process. Who knows, right? Human fertility, well, about frozen embryos, in vitro fertilization. Or what can we do for this? Or what are the rights of a surrogate mother, one who carries a child for a woman who's unable to do so? What's the right over the child? It's very common in USA, UK, well, in general in Europe and North America, to use the womb of a woman to get pregnant, not by naturally, just with in vitro fertilization, from a different ovule and spermatozoid, and this baby, well, this mother is just the womb. What's going on with the baby? Of course, the baby feels everything that the pregnant is feeling, but it's difficult how it affects, right? About transplant surgery or genetic engineering, transplant surgery. Who should give consent for removal of body parts for transplant surgery? The patient that is in brain death and in the situation to be the donant, or the family or the relatives or the spouse? Who's the best for giving that consent? About the genetic engineering, should we permit an embryo to be cloned? Why? Should we design our babies? Should we choose the color of the eyes, hair, the skin, the gender? Is that correct? Just questions for thinking on this. But one of the most controversial ideas that it's not going to change, in my opinion, is the assisted dying, the euthanasia. When you advise to follow this, you have to consider that it's an incurable situation. Palliative care is not working. The hospices for terminally ill patients, well, nowadays are so crowded, we can say. die with dignity is the idea instead of just die. So it's very, very important. Or if we have patients with persistent vegetative state, we should let them to stay connected to the mechanical ventilator. Well, what should we do? On this slide, we have this chart, just considering it as a general idea. And the blackened words are the vocabulary that is here developed. So consider this for reading, for taking vocabulary. I don't want to bore you reading this one. And keep educating yourself. Always. To stay up to date is the best way to do our best with our patients, right? That's all for tonight. I think it's not a long presentation, but it's very clear about what we are talking about. Let me send you the pool to take attendance. And I'm going to upload the slides to the Zoom chat, okay? So take it in count and give me a second. I'm converting the file. Is there any questions, something you would like to say? If there isn't, no problem. Oh, someone arrived. Okay, all of you fill the pool. Yes, all of you. Okay, it's uploading. It's my internet. I think it's not so fast. So give me a second, please. The same as Monday, as soon as you can download the file, please send a message to the chat telling me, yes, I could, or yes, it's possible, okay?
Okay, teacher.
Okay. I'm waiting. Okay, I'm going to check who can or who cannot in order to send by another way. Can you download it? Is that possible to do it? Okay, as soon as you get it, you can leave. That's okay.
Bye, teacher.
Bye, Gilda. Have a great night, everybody. Okay, perfect.
Thank you, teacher. Good night.
Okay, thanks to you. Thanks for your attendance. Let's try to send it again to the chat to Jasmine and Grace. Let's try it again. I'm gonna send to everyone. Okay, perfect, Paola. I'm gonna upload it again. Let's try Jasmine and Grace. If it's not possible, I'm gonna send it by to your WhatsApp. Just for you couple, okay? For you both.
It's not possible, teacher.
Okay, Grace, no problem. Jasmine, is that possible for you to download it?
No, teacher, I can't see it yet.
Okay, don't worry. I'm gonna send these slides to your WhatsApp channel, okay?
Okay, thank you, teacher.
Yes, don't worry about it. Sometimes it happens with Zoom.
Yes, thank you, teacher.
Okay, people. So see you tomorrow in the workshop, okay? Have a great night. Give me some minutes to send it.
Okay, teacher, see you tomorrow. Thank you.
See you. Bye-bye.
Okay, teacher, thank you. Bye-bye.
Bye-bye, Grace. See you tomorrow. Okay, Paula, I'm gonna close this. Let's stop the live stream. So see you tomorrow in the theoretical in the workshop. And okay, error. I don't understand, Paul. Why error? I can't. Okay, no, don't worry. I'm gonna send it to your WhatsApp too. Okay. Okay. So let's close this. See you tomorrow. Okay.